Hi everyone, welcome to the 4D show. Today, the topic that we're going to be seeing is why India is moving towards the capital of diabetes. So, there are many reasons. One is the Indian food is more of carbohydrates. So, even if you go to some house or anything, first thing they're going to give you is some carbohydrate dish as a sweet or something to welcome you in. And mainly, second, when you see Indians are more, they have fat than muscle. So Indians have less muscle mass and they have more of fat. We say sarcopenic Indians. So these could be one of the reasons why India is actually moving towards the capital of diabetes. Next, when we see post-COVID era, we've actually seen these work from home. People's activities have come down. Even securities these days want to watch the CCTV camera instead of going around the place for rounds. Children have stopped going out playing football, tennis. They play all the football and tennis in their phones, etc. So the physical activity per se is going to come. It's coming down day by day. So all these as a collective could be a reason maybe for saying that India is moving towards the capital, but definitely it's better we hear from the expert. So today we have with us Dr. Anusha, MD General Medicine. She's finished her DM endocrinologist. She's an assistant professor in Karnataka Institute of Endocrinology, Bangalore. And I am Dr. Prashant Tarun, consultant physician and diabetologist at MB Hospital for Diabetes. So now we begin the show.
Thank you, Dr. Prashant. Thank you for the kind introduction. And you rightly said, yeah, now technology is improving and technology is actually affecting the Indian population by making them more, inactive. So obviously that is making them prone for diabetes. Let me go through a few slides about this. Yeah, so I'll go through why India is actually becoming the world capital of diabetes. Next slide, please. So in India, there are 1 in 11 adults is living with diabetes. That is almost 1 in 2 adults with diabetes are undiagnosed. And over 53% of adults living in diabetes are undiagnosed. So as I told you, 1 in 2 are actually undiagnosed. Number of people with diabetes in India are second highest in the world. It's almost so many people are becoming diabetes because of this inactivity, technology, and Asian kind of obesity. That's mainly central obesity. And 40 million adults in India have impaired glucose tolerance. They're nothing but they are prone for future diabetes. The rise in the number of people with diabetes is driven by a complex interplay of socio-economic, demographic, environmental, and genetic factors. So 47,000 deaths are caused by diabetes. It's a very significant number, which has happened in 21. Next slide, please. So you can see in this slide the prevalence of the diabetes, which is more in the northern side of India, that is in Chandigarh and Punjab, and even Maharashtra, Gujarat, and even in the other side, its prevalence is approximately 5 to 6%, which is significant. Even in the Tamil Nadu, its prevalence is little on the higher side, that's 10.4%. Next slide, please. So, according to the ICMR, nothing but Indian Council of Research, they have done study, India diabetic study, the largest nationally representative hepatological survey conducted in India on diabetes and pre-diabetes. That's data from 15 states of the country. They have shown that the prevalence of the diabetes range from 3.5 to 8.5% in rural and 5.8 to 15.5% in urban areas. And the prevalence varied from 4.32 in Bihar and 13.6, which is highest in Chandigarh. Next slide, please. So, what are the risk factors for diabetes? So, first is overweight, that is usually caused by lack of exercise and unhealthy eating. Now, people are going for burger, pizza, and now the technology has improved, and the whatever food they want, that will be delivered to their house. So, they're eating more unhealthy. And physical inactivity, has Dr. Prashant told, after COVID, people are not moving out so much like before. They're working from home, so from morning to night they'll be sitting at home and they'll be in front of the computer. So that's why that's leading to obesity, and increasing age is also one of the risk factor for diabetes, and high BP, and also ethnicity. And family history is also important factor of diabetes. If both parents are diabetes, then you're more prone for getting diabetes compared to single parent. Next slide, please. So why Asian Indian phenotype are more prone for diabetes? Because they have certain unique and clinical biochemical abnormalities. So that includes increased insulin resistance because of their visceral adiposity. Uh, so they have, you have seen most of the Indians will have, abdominal adiposity, the big tummy, and that's that nothing but high waist circumference despite lower body mass index, and lower adiponectin that again increases the insulin sensitivity, and higher high CRP protein levels, that's that is prone for coronary artery disease and also to diabetes to some extent. This phenotype makes Indians more prone for diabetes and premature coronary artery disease. So, along with that, obviously, genetic factors plays a role in, to some extent. No. Next slide, please. So, lack of exercise, as I told you before, so now people are moving, out less frequently compared to previous days. So, if you do exercise of any kind, which move your muscle or your limbs to some extent, that is going to use insulin and glucose more effectively, thus lowering diabetes risk. So lack of exercise can cause this insulin resistance. That means muscle cells will lose their sensitivity to insulin, which control levels of sugar in the blood. So according to a survey by an insurance firm, around 30% of the Indians aged between 18 to 47 years do not have any form of physical activity. That's a huge 30% is a huge, big number, and particularly in urban areas. So in rural areas, since they will go to farm and they will be involving in one or the other vector for day to day active living, so they won't have that prevalence compared to the urban people. Next slide, please. So sedentary lifestyle is becoming more because of increased technology, I would say. Because, for example, now if they want to order some vegetables, previously they used to go out and get vegetables and whatever things. Now the Dunzo and other, because of increased improved technology, everything is coming to their door. So they're not moving. They're just like sitting at the same place, and in this even work from home, as I told you before, that is also making them more sedentary. Previously, they used to get ready and go out to office, and some activity, some movement used to be there. Now they'll be sitting only in front of the computer. So India is one of the fastest growing economies in the world. The country is currently undergoing a rapid transition with increased urbanization, as I told now, through the country. For example, the urbanization rate was 35% in 2000 compared to only 8% in 1952, almost like 4 times it has increased, and this had a major effect on health of the population. Studies have proved that socio-economic development over the last 4 decades has brought tremendous change in lifestyle, leading to the reduction of physical activities because of this technologies and advancement, and hence leading to the consumption of because of that, there increased consumption of sugar, fat, calories, and also increased stress. This has led to the obesity and sedentary lifestyle, which ultimately disturbed insulin production, that is insulin resistance, and that's causing the diabetes. That is the reason why diabetes among urban people is becoming more compared to the rural compartments, both in North and South India. Next slide, please. So, obesity, all these factors are leading to the obesity. So, it's becoming the major risk factor for the diabetes, and there has been little research focusing on this risk factor across India. Despite having overall, lower weight, obesity, they'll have more central obesity. So that's how they are more prone for diabetes compared to the Western people. So relatively lean Indian adults with a lower BMI can also have diabetes, though they're not obese because of the visceral obesity and insulin resistance. And Indians are genetically predisposed to the development of coronary artery disease due to dyslipidemia and low levels of HDL. These factors make Indian prone to the development of complications like diabetes with a very early age, that is like around 20 to 40 years, compared to the other ethnicity people, that indicate that diabetes must be carefully screened and should be properly monitored, regardless of the patient is with India. Next slide, please. So the most disturbing trend is shift of the age of the onset to the younger age. Nowadays, I'm seeing patients at the 20s also, like especially patients who are obese. So that's a very bad sign, because they're supposed to live with this diabetes for pretty long, like 40, 50 years. and they will end up with having complications, coronary artery disease, kidney disease, and retinopathy. I've seen people losing their eyes at the end, very young age because of the younger onset of diabetes. So there is a now you can see that 60.5.7% of overweight are obese in the age group of 20 to 30, and 62% felt obesity impaired sexual performance. So across all age groups, 80.7 are overweight or obese. Obesity was higher among women compared to the men, and medical complications due to overweight or obesity is the main concern, and only 3.5% of the knew that the obesity can lead to the diabetes, and 100% of there is link between the obesity and heart disease. How to manage diabetes in Indian people? So since after 30 years, our metabolism will come down. So we should concentrate on our diet and regular exercise, especially the carbohydrate, how much carbohydrate we are going to consume, especially the refined carbohydrate, that is sugar and starch. So we have to concentrate on that, and you have to do at least 1 hour of moderate to physical activity, and you have to keep an eye on blood sugar. So according to the recommendation, you have to start screening for diabetes at the age of after the age of 35 years, especially with the people who are having risk factor diabetes. And you should be very regular with the medications, and along with that you have to concentrate on the cholesterol also, both on the diet and how to take regular medications. You have to take care of kidney, eye. Those are the complications of diabetes, and you have to lose weight. That's a very important factor of diabetes. If you lose at least 5% of the weight, the HbA1c is going to come down by 1 to 2%, and practice good oral hygiene. So main thing is you have medication, concentrate on yoga, exercise. You have to eat balanced nutritional food. You have to do carbohydrate counting before eating, and you have to monitor your glucose regularly. Next slide, please. So Indian diet is like we eat, especially we eat more of rice compared to the Western people. That is the one of the reason for central obesity and prone for diabetes. So we have to concentrate on diet with low glycemic index. That is nothing but whole wheat, brown rice, oats in every meal, and you have to avoid food containing refined cereal products, that is wheat bread, noodles, white rice. So exercise should be done regularly. So along with that, you have to monitor the blood glucose. HbA1c should be done either once in 3 months if sugars are not under control, or once in 6 months. That should be done along with the fasting and postprandial. And medication should be taken regularly in the recommended amount and recommended schedule. Along with that, diet and exercise. And missing medication can increase the risk of suffering from several diabetic-related health complications. Next slide, please. So there are many drugs which are coming up to treat diabetes. It's a good thing actually, because you not go for insulin immediately, because most of the Indians won't be ready for insulin. If we tell insulin, they'll be like, no insulin. The good thing that many drugs are coming up. So along with diet and exercise, we can use these DP4 inhibitors, that is sitagliptin, saxagliptin, linagliptin, alogliptin, and SGLT2 inhibitors, canagliflozin, dapagliflozin, empagliflozin, and that helps you to reduce the weight also. And GLP-1 receptor analogs, that also nowadays it's coming for weight loss also. Example is semaglutide. Early initiation of combination therapy. So it is an approach to achieving glycemic goals earlier and delaying the deterioration of glycemic control, and with possible better preservation of beta cell function. So example is metformin, and SPGL2 inhibitors provides the combination of early efficacy and reduced risk of hypoglycemia, along with that weight loss, BP control, and cardiovascular protection, and also renal protective. Next slide, please. So guidelines on SGLT2 inhibitors and DP4 combination to manage blood glucose levels are. So for stabilization, this should be initiated at least 2 to 3 weeks before fasting, someone is fasting, and this combination is recommended to be administered at the time of breaking the fast. However, if the indication of this combination is cardiovascular and renal protection, then the pre-fasting initiation should be conducted with a lower dose. So when you take this combination, you should be increasing the fluid intake with an adjusted dose during non-fasting hours, and this combination does not require treatment modification during fasting.
So I think that's the end of the presentation. So
Okay.
we had a wonderful presentation. So we were actually seeing that actually one of the points that you said that is rightly said in India, when we actually tell somebody that you will have to be started on insulin, first thing they say is, let me try tablets for some time.
Yeah.
Even if
If
they
I say,
have,
yeah, actually, if
yeah,
I say that, they'll fear and they start, actually taking medication properly and they concentrate on diet and exercise. And that
yes,
insulin is.
yeah, because even if they have a high glucotoxicity of 400, 500 sugars, first thing they ask is, can we try tablets? Because
Yeah.
I think people they are unaware of the beta cell loss at that point of time. So even at least for a very short period, it's better that we give them insulin. So
You're
can you just
absolutely right.
tell us about the different types of insulin, that is basal, bolus, short acting, long acting? So what are the types of insulin available to be
So,
treating diabetes?
yeah, you can get, you will, short acting, intermittent acting, and long acting. So nowadays, ultra short acting is also coming. That's very good for Indian population because Indian population will have more of postprandial glucose. High glucose, and for them, ultra short acting, which is coming now, the insulin analogs. That's that's good for Indian population. And short acting is more of regular insulin. That is atropine insulin, which we used to use very commonly previously. But after this analogs have come, that still it has its role, but people are using that more frequently. Other one is intermittent acting, that NPH, that will act for up to 12 hours. And last one is long acting, that's also called as insulin, that is glargine, glutamat, glutamate. That will be action will be there from uh, you know uh, 18 to 24 hours, depending on the which insulin you use. That can be given at least one. You can start with once a day dose kind of.
Yes. So, what is your opinion on maybe starting? Because all the guidelines definitely say start with metformin first. Metformin is the first line of
Yeah.
therapy. But what could be, where would you use an SGLT2 inhibitor as a first line? Would you use an SGLT2 inhibitor as a first line? And which patients would be that you using SGLT2 inhibitors in the first line itself?
So I would start with metformin because in Indian population, insulin resistance will be more. That is the one of the important mechanism of diabetes. So I would start with metformin, but I can use as second line, or like if sugars are high, I can use metformin and SGLT inhibitors. But I won't use only this because the mechanism which I want to concentrate is insulin resistance. They'll have central obesity and that, and also to SGLT I would use because for weight loss, especially the obese patient who weight loss is going to help. Such patients I would, and
Oh,
cardiac and if they have cardiac and even though recommendation says even they if you don't have diabetes with normal HbA1c, you can start HLT inhibitors. Such cases we can start.
yes, definitely. So, in because generally the SGLT2 does not work when the EGFR is less than 30. But
Yeah,
again, we see many cardiologists been still using the EGFR up to 22. They still use the
yeah.
SGLT2
In a study they have used up to 25.
25.
Yeah.
Okay.
So EMPA they have used up to 25. So
Yes. So just can you, for our audience, because we've got not only doctors, we've got many patients who don't even know these SGLT2 inhibitors in this. So can you name out the SGLT2 inhibitors for them so that they'll know what drug they are taking?
yeah. So in the market, there are three SGLT inhibitors we commonly use. That is dapagliflozin, empagliflozin, and dapagliflozin. How it acts is like it increases the glucose secretion in the urine. That's how you lose weight and you'll have other benefits of medication.
So now that there is a thing that when we use the SGLT2 inhibitors with a combination of DPP4 inhibitors, actually it avoids the risk of urinary tract infections, and the action of the SGLT2 inhibitors is much
Yeah,
better when you combine it with the DPP4 inhibitors, which is why we
yeah,
have the combination therapies available. Can you throw some
yes.
light on that, please?
Yeah, studies have shown that if you use actually this DPP SGLT inhibitors, if you use alone, there is risk of UTI and genital infection. That's I've seen very frequently. But yeah, studies say that if you use in combination, the UTI risk is less compared to using alone.
Okay. So, but generally, yes, definitely, yes, SGLT2 inhibitors are more prone of developing UTI because, again, as the glucose excretion in the urine. But not only that, because most of the patients with diabetes, when they are when they are not under control, maybe they have a lot of urinary sugar excretion, and which itself is a risk factor for urinary tract infection.
Yeah.
So definitely we cannot put the blame completely on the SGLT2 inhibitor because you don't know.
Yeah, many people stop medications because of that.
They read some article or somebody next to their house, just go tell them that the SGLT2 inhibitor is bad, you take it, you'll develop urinary tract infection. It's maybe not the urinary tract infection.
Doctors are scared if they have UTI because of high sugars. Even they are scared to put SGLT2 because...
Yes. Yeah. Could you explain the diabetic diet, your idea of a diabetic diet?
Okay, so my basic thing is low carbohydrate, low calories diet. Food which contains low carbohydrate or more of should avoid refined carbohydrates. That could be sugar, rice, starch containing like aloo, maida. All these three. Hello.
Yeah.
All these things should be avoided. And what you should if you take a plate, it should be a balanced diet. So if you take two chapatis, the half of the thing should be vegetables. Okay, remaining 1/4 should be protein, and remaining 1/4 should be whatever chapati or roti you want to. It should be in the only 2 or something. Should have balanced diet.
Okay.
And you should take food containing low glycemic index. So it can be oats, wheat. That would help to control the sugar.
When can we restart this SGLT2 inhibitors once we stop for a patient with UTI? How long do we give them time?
It depends on what kind of UTI. It's a simple UTI means you can, after once they recover from the UTI, you can start. But if it is complicated, I've seen people going into pyelonephritis. Such patients better to avoid.
Yes. Because SGLT2 actually inhibitors even help in proteinuria because most of the people with diabetes have hypertension.
Yeah.
So being the high BP also could actually produce the proteinuria, and actually the SGLT2 inhibitors help in reducing the proteinuria where the people can actually save their kidneys.
Yeah.
So I think SGLT.
Yeah, it has like multiple effects in that way. It will control the glucose, it will lose weight loss also. Again, it will help for BP control. It will decreases the BP, it will decreases the proteinuria. So like that, it is renoprotective also.
Yes, and moreover, this talk is actually a public awareness program on the triple drug combination. So when we conclude, I would like to get your opinion on what you feel about this triple drug combination.
Triple drug, see, now many Indians, compliance is one of the problems. So if you put them on multiple drugs, they might not take it. They might skip afternoon I forgot that, night I forgot that. Compliance is one of the factor for uncontrolled and for future complications. So triple drug combination helps them to be compliant. So they can take 1 medications per day or 2 medications per day, depending on that. Along with that, yeah, if you combine this with other drugs, they say complications are less. What I'm saying is mainly about SGLT inhibitors. If you combine with other 2 drugs, complications are less. The effect also is more of synergetic effects. All 3 drugs is going to help you more compared to the So I would say this is a good thing, especially for the Indian population.
Definitely, and cost also comes down. Actually,
cost is only important because if you take 3 medications separately, cost is going to be more compared to the combination of the drugs. So example, now recent combination drugs have come, it's coming up to 90 rupees if you take one drug. But if you take every drug individually, it is coming up to 26 or 27. So they're going to save significant, 5-6 rupees. That's a significant number when you take in a bulk.
Sure, definitely. So it was wonderful having you here in our session. We have come to the end of the session for today. And we've again heard about why India is moving towards the capital of diabetes. So it was wonderful having you here. So thank you. Thank you everyone for watching our session also. Thank you.
Thank you, Prashant. Thank you so much for the opportunity.